Hello, everybody. On behalf of the New England MHTTC Early Psychosis Learning Collaborative, I am really excited to welcome all of you to the first of a series of online discussions about implementing real-world evidence-based services for early psychosis and clinical high risk for psychosis. My name is Michelle Friedman-Yakubian, and I'm calling in from Boston. The goal of this series is to bring together leaders, clinicians, administrators, and other stakeholders who are interested in working together to increase the feasibility and scalability of specialized early psychosis and clinical high risk for psychosis treatment. We have a great group of guest presenters who will share their experience with finding ways to pay for and develop high-quality prevention services for youth and families affected by early psychosis or clinical signs of risk. The format of each discussion in the series includes a 30-minute presentation by an invited expert, followed by 30 minutes of questions and discussion by participants. We really want to hear from all of you about this, and in order to really begin to develop some ideas that might affect change. So I'm really glad you're all here. Feel free to type in the box at the bottom to introduce yourself, and my colleague Rationale will be providing some housekeeping information.
Oh, next slide, please. Hi everyone, this is Rationale. I'm the project coordinator for our Early Psychosis Learning Collaborative at our Harvard site. I just wanted to review a few housekeeping items with you all before we begin. So participant microphones have been muted as you entered, and you'll be able to unmute them during the discussion portion. During the presentation, if you have any technical difficulties or questions about the topic, please use the chat or the raise hand feature during the discussion to have your microphone unmuted. This discussion is being recorded and will be available for viewing at a later time on our MHTTC website. And to reach us after the webinar, you can email newengland@mhttcnetwork.org. And on our next slide, our MHTTC's mission is to use evidence-based means to disseminate evidence-based practices across New England. Our area of focus is geared towards recovery through recovery-oriented practices and support services within the context of recovery-oriented systems of care. And then on our next slide, to ensure the responsiveness of our work, we will actively develop and maintain a network composed of different stakeholders from each of the 6 states to guide our activities. And then on our next slide, to learn more about us, you can visit our website as well. And with that, it is our pleasure to announce our speaker today, Dr. Douglas Robbins.
So I'm happy to introduce Douglas Robbins. We have a wonderful presenter today. Dr. Doug Robbins is a child and adolescent psychiatrist with Maine Behavioral Healthcare in Portland, Maine. He is a clinical professor of psychiatry at Tufts University. He was the director of the Child and Adolescent Psychiatry program at Maine Medical Center for 20 years. And he previously was on the faculty at Brown University and Bradley Hospital and at the University of Michigan. He has been involved throughout his career in early identification and treatment of serious mental illness in children, adolescents, and young adults, including mood disorders and schizophrenia. He was the medical director for the Coordinated Specialty Care Program for First Episode Psychosis and Clinical High Risk for Psychosis in Maine. He is currently working on broader implementation of evidence-based treatment for severe mental illness in young people. Dr. Robbins, thank you so much for coming today, and we really look forward to learning from you.
Well, thank you very much, Michelle, for this opportunity. I'm really looking forward to this and really expecting and hoping this is going to be a two-way process, and I'm going to come away learning a lot more about what's going on around the country and how we deal with some of the barriers to implementation. And I think this is really, as you've said, this is a kind of a piece of the broader field of implementation science, and which is really critical because we know lots of things in this world, and we know it can take the so-called implementation gap of 2 decades before evidence just cooks down to actually being used on the street in our program. So this is really, really important. So let me get started. I'd like to try to move through this. It's a fairly, in some cases, kind of dense amount of material. Kind of go through it kind of quickly to leave plenty of time for discussion, and we can circle back to things that need a little more clarification. So for starters, I guess it's worth just saying, I think we are at a interesting point in history. I think for a long time, for millennia, we hoped we could do something about serious mental illness, but now there's evidence that we really can. In addition to our wishful thinking and fond hopes, that we really can, that we have evidence-based treatments, and if we could scale them up to a population level and address the population health, improvement objective, we can really make some major differences for people. And so, we'll come back to the rationale, but basically there are two parts of it. One is we can really improve the life for many, many people and their families who are also enormously affected, but also that we can use limited resources much more carefully. We can decrease costs for healthcare, or at least use them in the worst case scenario, use what we're already spending much more wisely and really have much better outcomes. And there's evidence for this as well, both short-term and long-term. Short-term, we see reduction in use of emergency rooms, crisis services, psychiatric hospitalization, and in the long-term, we see decreased costs in multiple domains, not just in psychiatry. We'll talk more about that. A huge barrier in this, or challenge, is that there really is not sustainable funding through insurance or other mechanisms to do this work. Large industries, of which we are one, are intrinsically cautious and conservative and don't move quickly. And new ideas often confront the problems of not having funding mechanisms that keep up with the evidence. Beyond that, I'd say there are some really very fundamental assumptions or paradigms about mental health treatment that we need to have in mind. And this can seem kind of dark and pessimistic, but I think the fact is there is pessimism that you can really fundamentally improve treatment for severe and persistent mental illness. Pardon the acronym there, SBMI. A certain skepticism that investing in better treatment or different treatment will really change the picture of the health of this population group. And just from a kind of banker's perspective, the return on the investment is limited or questionable. And I've had some people who are really, who I truly think have their hearts in the right place, say, that all sounds good, but I'm not really sure it really ever pans out. Well, the fact is that it does, and we'll come back to that. But we also have to know that current treatment as usual, really has very limited effectiveness, and we need to do better. But we also have to resist the kind of skepticism that we don't know enough to do that now. You see some things, even a very recent article in the American Journal of Psychiatry, basically saying, let's put all our marbles on finding those wonderful biomarkers that are going to tell us who needs what and how to do it. And so that could be a generation or a millennium from now, hopefully not. But the point is that we have tools we can use right now that we know are effective. I'm going to say more about that. And again, there are two parts of the rationale. One, or I should say that much of the thinking about doing more in mental health is because it seems like it's the right thing to do. It's humane and ethical to people who are really suffering, but that fundamentally the expectations are rather low, that we're really going to make a difference. And I want to challenge that. One of the effects of this sort of chain of pessimism and skepticism and fatalism is that we really put out the resources only when we really have to. If somebody's suicidal or terribly, terribly ill, then they go to the hospital and they run up huge, huge bills. And so resources are disproportionately used for the more severe end of the spectrum. So what I think we're building the case for is a new paradigm, a new way of thinking about serious mental illness, that early identification and evidence-based treatment is truly good public policy. It's a critically needed investment in the health of the population, and that with currently available treatments, we can markedly improve outcomes for individuals and decrease the burden of severe and persistent mental illness on healthcare resources and society. And also, as I'm saying, we already know how to identify earlier many of the people who have have serious mental illness who are at markedly increased risk for serious mental illness. I'm not all that old, but when I was a resident, we were told, hold off on those serious diagnoses like bipolar and schizophrenia until you're really, really sure that's what's going on. And so consequently, the textbooks would say that the typical age of onset of, say, bipolar disorder and schizophrenia was in the mid or even late 20s, when in fact we now know these things have started a decade or even way more prior to that. Context that we have to think about here, one is the whole concept of value-based healthcare, not just looking at costs, but looking at the benefit that we're getting for those costs. And someone who's written about this quite a bit is Michael Porter. And you see a couple of references to his work at the end. And again, I mentioned the implementation gap, that we can have new treatments that we have proven to be, the studies have proven to be effective, and a long, long time can go by, 17 years, 2 decades, before they're actually put in broad practice. So to just overview, so basically we're going to talk about how do we move towards more sustainable funding, and particularly insurance funding, and want to sort of go through these different parts. First of all, it's a major education piece. We need to turn around thinking on the part of all sorts of stakeholders, whether it's families, primary care, and other healthcare providers, others who deal with young people, like people in schools and colleges, and certainly the payers, whether that's the taxpayer and Medicaid and Maine Care in Maine, or commercial insurance. And we need to make it clear that in addition to the fact that the treatment works, it's cost effective. And we'll talk more about that. We have to be very careful to define our costs and cost effectiveness and the return on investment. One of the worst things we can do is to overstate our case, so we need to be careful about this. Third, I'm going to talk a bit about different funding models that are being considered for this, that are ways that this kind of treatment could be covered by existing insurance. And then we're going to talk specifically about Medicaid, and then finally commercial insurance. So again, who to educate? The public. This is families, schools, primary care, anybody who deals with young people, healthcare providers, our own organization and leaderships, colleagues. And we would sometimes assume that our very own hospitals and departments are all for this. And there's some wrinkles to that. We all can get stuck in the status quo, can get locked into what we've programmed for next year's budget, and be reluctant to make changes. So it has to start really at home. And then certainly also with the people who pay the bills, whether that's state Medicaid leaders, insurance company people. And I would emphasize also benefits managers for employers, because they have real leverage. They can say what their employees, and particularly in the larger companies, they can say our people need the following, and insurance companies listen to that. So I'm not going to go in detail into the treatment model itself. That's a whole nother seminar, or 2 or 3 or 5 or a ton. But basically, this model that is evidence demonstrated to be effective, it's called coordinated specialty care. It comes out, it's been demonstrated internationally well before it got really studied in the United States. But in the US, there's an initiative called Recovery After an Initial Schizophrenia Episode, or RAISE. Major studies done and published by John Kane, Lisa Dixon, Rob Heinsohn at NIMH, Vinod Srihari at Yale, and I have those references at the end. But these all kind of converge on a group of components that I've listed here. And I would emphasize that a good program really needs to have all of these components, because some will be meaningful for some patients more so than for others, and other things are just universal across the board. The first one, team-based care. If you do this by just trying to have a case manager in one agency and a therapist somewhere else and somebody else across town managing the medication, you're going to not get good outcomes. Even if each of those individual clinical people is very good and skilled, the process of sitting down at a table once a week, twice a week, whatever the frequency is, but on a regular basis to view the roster, call the roles, see who's doing well, focus in more on those who really need it. This is really critical. This has been proved again and again, particularly in the world of assertive community treatment, or ACT, which is clearly effective. And to an administrator, a team meeting is a very expensive proposition. You've got maybe half a dozen or a dozen salaries sitting around a table and not sending in a single bill, and they kind of blanch at that concept. But the fact is, this really makes it work. Case management, care coordination, this has been proven across diagnoses. So anyway, I'm going to stick to what I said about not going through all of these elements, but they're all really important, and we can come back to specific questions about them and both their clinical role and also financial issues later on. Briefly, in talking with people, we need to be able to make very clearly the point that treatment really works, that early treatment works. And this goes back to the 90s. A study by Richard Wyatt in the 90s was finding that among people with schizophrenia, those who ended up on antipsychotic meds earlier in the course of illness as opposed to later were doing much better. And so there's been considerable follow-up on this idea of getting to people as soon as possible after the onset. And that's the final point on the slide there. Outcomes are better with a lower duration of untreated psychosis. That's a recurring reality in all of these studies. But we see people better in terms of employment and education. There's a decrease in hospitalization and overall healthcare costs. There's fewer of these people go into jail and corrections, and this is critical. There's just an article in the Times restating what we all know, which is that the largest mental institutions in the United States are Los Angeles County Jail, Cook County Jail in Chicago, and Rikers Island in New York. And that's pretty dismal. And indeed, I'd say some of the people in our own program have come into treatment with us in lieu of going to jail, and it's made a big difference in some people's lives. Improved quality of life, and there's a real science about that. That sounds like a very general term, but that is something that can be quantified and studied. Improved relationships with families, housing, medical care. Many of these folks, as we all know, end up homeless. Medical needs are huge. They die 25 years too early. And there's evidence for every statement on this slide. And that summary article by Lisa Dixon, Howard Goldman, Vinod Srihari, and John Kane that I've listed at the top and again in the references really provides some of the background for this. We found it's very useful, and I would encourage people to pay attention to this part, to use whatever you have in terms of local data. It's very useful. Eyes kind of glaze over if you say, well, this has been proven to work in Denmark and Norway and Italy and the UK, and that's all on another planet from the perspective of most of the people you're going to be talking to. And also national data, even the RAISE studies, it can sound a little abstract, but if you can say it's right here, it's here at home, and maybe some of you in the group I'm talking to have a son, daughter, or nephew, or a spouse who's been involved with this, that really hits home. So this is just very quickly our local data that we've used. We measured disability with something called the World Health Organization Disability Scale, and you see the downward trend of these three diagnostic groups suggests that overall disability is indeed coming down, and there's interesting differences. There's another discussion, but the fact is the trends are towards less disability over a limited period of time. More people in school and work. This is a critical dimension because treatment as usual would have all of these lines being pretty much flat or descending in follow-up after a first episode of psychosis, with fewer and fewer people going to school or going to work. Hospitalization drops significantly, and this is a biggie in terms of making the financial cost, because this is where all the money goes, a lot of the money goes. And as you see in our program, most people, 70%, came in having recently been hospitalized, and then during the course of treatment, very few are hospitalized. And those who do go back into the hospital tend to have short hospitalizations. Srihari's work supports this as well, because we have a team that knows them very well. More on cost effectiveness. The study by Srihari and others, economic analysis by Murphy, show a marked drop in hospitalizations, marked drop in the length of those hospitalizations, fewer overall bed days used, and savings in terms of hospitalization are substantial. If you can cut down the number of hospital days by 6 days over a year, that's thousands of dollars right there. And in that program, which is the one in New Haven, there was an overall increased outpatient cost of about $2,000, as you see. But when you factor in the reduced inpatient cost, you have a net gain of nearly $3,000 within 12 months. So to speak the language of the people we need to talk to, this is, a return on investment in this fiscal year. This is not down the road. A big study of programs around the world done by people in the UK also found very similar findings, decreased hospitalization. And while community mental health costs go up, hospital costs go down, and you have a net savings. The RAISE study, there's a detailed analysis by Rosenheck and all, and using a analysis called incremental cost effectiveness ratio that shows consistency with the concept of cost effectiveness. And what's particularly notable, I think, is the second item there, cost per quality adjusted life year, is comparable to things that we always do and would never question. Like, what does it cost to put somebody on statins for hyperlipidemia? They haven't had the heart attack yet, but if you put them on statins, their course is going to be better. What about chemotherapy for cancer? Nobody would challenge that, even when it's incredibly expensive. And care for common medical problems like diabetes, coronary heart disease, and so on. The fact is that the amounts of money we're talking about spending are right relative to the degree of improvement in people's lives, is right in line with what we do commonly in the rest of medicine. That review by Asitino is a big review of international studies around the world with similar findings. Now, the key things, to get into the really important things, most of this treatment model is not funded well or at all by health insurance. And you'll see the items in orange here. You cannot put in a bill for team-based care unless you're in some unique category where you might get Medicaid funding. You do not get case management. Family education support is partially paid for. Routine family or conventional family therapy sessions might be paid for. Family group psychoeducation, which can be very effective, is insufficiently paid for, and so on. But you see all of these elements, particularly supported employment and education. Insurance is not interested in paying for that, and yet when you include all of these things, it really makes a difference. And at the last, community education with the importance of this, and this is really something to pay attention to. And then the outreach to engage patients and families before they're actually registered as patients, but to get somebody who's just recently come out of a hospital with the first psychotic episode to engage in treatment, that takes a fair amount of work, and you're not going to be able to bill for that in many cases. Only when the person and the family sign on, then it may fit into whatever insurance they have, and that will have all these limitations. I guess the point here is, what's the best you can do with current insurance funding? And I would point to this study from On Track New York Tom Smith and others, Lisa Dixon, saying that even with optimal billing, with Medicare waivers for more flexible use of Medicaid waivers, and those are waivers that most states do not have at this point in history. At best, you can get close to half the cost of the program covered. And in fact, it's more like, in our experience, a quarter of the costs are covered by insurance. Now, the mix or payer mix in this population is variable. In our program, about 20% are on commercial, about 20% are on Medicaid and 50% on commercial. And so this varies back and forth. And in a more rural, less economically stable environment, you have to expect more people on Medicaid. Now, there are these other sources of funding. The Community Mental Health Block Grant, the 10% set aside for serious mental illness, is really critical. It's jump-started programs all over the country, including our own. And that's great, but that could go away with a change of the political winds, and that's always a risk. And also, there are huge needs. They may not always be focused only on psychotic disorders, so we need to not count on that excessively. And in our own case, that manages part of what's necessary for a statewide program, but not enough to run an entire statewide program. Now, how much does this treatment cost? And this is a devilish question because the reported numbers are quite different around the country, as you'll see at the top of the slide there. The cost per patient per month may range from $1,200 to $2,200, and I'll say a little bit about the variability. So overall annual cost may be $14,000 to $26,000. Now, that's offset. That's what it costs to do this. This does not factor in the offset of decreased inpatient costs. So this is not the net cost. This is just what it costs straight up out of your outpatient silo of funding. And the variability in these costs includes variations in what's included. The education, outreach, training, family education, outcome and fidelity monitoring, peer support. A lot of these functions in many cases in some cases, the more expensive ones are rolled into a per patient per month cost. In other cases, those same functions are paid for by something else, like they're taken out of the mental health block grant or other kinds of funding. Overhead and margins that are often added in health insurance to anticipate various problems that may come down the line. So there is variability. So when we talk about costs, we have to be careful what we're including and what we're not including. We also have to make the case that in addition to monetary costs, direct healthcare costs, there are many other kinds of costs that are not covered by health insurance. One of the biggest is number 2 on this list: patients and caregivers lost productivity. The patients are often not working for their lifetimes or major parts of their lifetime. Caregivers, family members, are often cutting back what they're doing, or maybe one of two parents will stop working. Families have very high out-of-pocket costs in many cases, particularly with today's high deductible policies. And this is also paid for in completely other domains or silos of funding: education, law enforcement, and corrections, and in welfare through the cost of homelessness. And also, I would add foster care for offspring and mentally ill and substance abusing adults. This is a rapidly rising category. It's largely attributed to the opioid epidemic, but it's that and more. It's also a consequence of undertreated severe mental illness. So again, what's the rationale? What are we trying to say here? First item in why we should do this is not that it's going to save money, but it's the right thing to do for healthcare. And I refer to the goals of the quadruple aim, used to be the triple aim, but improving population health, containing costs, improving the patient experience, and now also improving the work experience for providers, which is critical as well, if people are not going to burn out and retire early and all that kind of thing. The concept of value-based healthcare I referred to earlier, that's important. But also we really can reduce the overall cost burden. And if we're intervening in the first year and improving the trajectory of function for these individuals over time, that means that over time there would be a decreasing block of the population that can be classified as severe and persistently mentally ill. So it's not ridiculous to think that down the road we could bring down the overall burden that society needs to pay for severe psychiatric illness. I mentioned medical morbidity. It's well known that people with serious mental illness die about 25 years too early, or earlier than their counterparts. And I'd also say, and this is important in talking with healthcare systems, anybody in primary care will talk about the enormous cost in terms of their own efficiency and what happens to their schedule on a busy day when they encounter somebody with serious mental illness. So the efficiency of other components of the healthcare system is impacted enormously and needs to be treated more effectively with more collaboration and integration with between other medical care and mental health care. So different funding models, just to mention these briefly, and this all gets a little bit complicated, but there's a lot of reason to think the idea of a bundled payment or a case rate, a single payment that includes all the components in a single charge, really makes sense. You can use this, you can compare this with outcomes and have assessments of accountability for effectiveness. It's efficient. You don't have to have millions of people doing lots of different codes and all that overhead. So there's a lot of, and it can be done in different ways. There are arguments for doing it on a daily rate or days in which there's an encounter or per month. I'd say the per member per month approach is probably the simplest. But the general idea of bundled payment is really important. We see in some of Michael Porter's and other people's writing, and in journals such as Health Affairs and other administrative and policy publications, a lot of emphasis in the use of bundled or case rate approaches to payment for disease categories. This is not just mental health. This is diabetes, cardiovascular disease, and other things. Another option is that we continue to use the billing codes we already have for things like medication management, psychotherapy, and then have essentially a hybrid with an alternative payment or a limited kind of bundle for the other things like supported vocation and employment and the other things on the list that were in the orange color. There's been a proposal, and I'll say a little bit more about if you're using the Healthcare Common Procedure Coding System or HCPCS codes, and these are used in other areas of medicine to pay for things like rehabilitation services and things that don't necessarily happen in the doctor's office, but are really critical to overall outcomes, like the rehabilitation component following a myocardial infarction. If you don't do that, people don't survive. And yet it doesn't all neatly fit into CPT codes and typical billing. And we'll talk more about the Meadows Institute. They've proposed a model using that, and here's a little bit more about that. And they have, they note that this is comparable to and this is the idea of a case rate or a bundle is comparable to how assertive community treatment, also systemic therapy are paid for. These are well accepted, known to be effective and cost effective. They also have built in a way to account for different intensity of service. We all deal with the fact that people get better and then they don't need everything. They don't need all of the components. They might need 2 or 3 with some degree of ongoing careful attention. It's going to make them not do well in treatment as usual. But building in a way to account for different levels of intensity is important. I'd mentioned an interesting model being developed in Washington State and Illinois. In Washington State, they're phasing in coverage in 2 steps. In the first step, doing conventional billing for the services that have coverage and using the mental health block grant to pay for the rest. Meanwhile, studying what the overall costs are over a period of time so that they can come up with a comprehensive case rate. And their thinking is that they would start with a pilot program with their own state employees health plan to be able to look at this in a kind of smaller block of people, block of population. Illinois also has a kind of phased-in coverage of Medicaid and an ongoing working group to look at rates and costs, with the idea that it's hard to know all of that right up front. I mentioned the variability previously. Just a quick scan of what's going on around the country. Oregon really is leading the country in having a statewide network of services for early psychosis called the ESA program with Tamara Sale and others. And they've negotiated Medicaid coverage for parts of that. Pennsylvania has provisions for Medicaid services in the PEACE program. In eastern Pennsylvania, the Philadelphia area is one which is heavily dependent on Medicaid and it's able to do very good work. There's, in some cases, legislation is being used to require Medicaid coverage, and we're on that list, and it's really started during an era when we had a state executive branch that was not simpatico with this idea and was spending more on public health care. And there was strong support of the legislature, and that's still in process. It's passed the House, not yet the Senate. Illinois and Washington State both have passed legislation which mandates Medicaid coverage. It makes has the states develop Medicaid programs, as I mentioned, and also includes an expectation that commercial insurance will develop coverage. And in both cases, that lags behind. It's really getting started more on the Medicaid side. Some steps in defining coverage that we all have to be careful about. We have to, it's inevitable. We need to know how many people we're going to serve. So what is the eligible population, the number likely engaged? And that's not the same as the prevalence of these disorders that we're going to read about in the textbooks. Because the question is, of the, let's say 1% of the population that has schizophrenia in terms of lifetime prevalence, how many will have an incident first episode within the past year or two, depending on how we define this. And that's a very different figure, and that's not as clear as it might be. Among those, how many of those would be on Medicaid? So we can say how many might need that funding as opposed to commercial insurance, because that's going to relate to what is the federal match and reducing the amount that the state is going to have to pay. And then there's going to need to be discussion about ways to use state Medicaid funding more flexibly through waivers, the 1115 waiver, or by developing what's called a state plan amendment. There's a lot of steps in that. The article by Humensky and Dixon and Essick, 2013, called an interactive tool to estimate costs and resources in New York State is very helpful. And you also see quite a variation that allows for differences in costs in different areas. Things are different in rural areas, suburban areas, urban areas, different parts of the state, different levels of economic well-being, and so on. So that's an important, useful article and guide. Commercial insurance is a whole other bag, another story. And at this point in history, well, we've made some progress that I'll talk about. This is not really active anywhere in the country. There has been some progress, but it's not really active. I think there's a general conservatism about new innovations right now, with a lot of the flux about what's going to go on in health insurance nationally. It's really, and a lot of questions have been there with ever since the Affordable Care Act. A big issue that's currently referred to is this item here, that severe mental illness is perceived to be a small population in cost relative to major medical illnesses like heart attack, stroke, and cancer. Well, I think the key issue here is that it's small, but it's disproportionately very expensive. There may be 1% of the population have schizophrenia, another 1% have bipolar disorder, somewhere in those categories. Well, these people do cost a great deal over their lifetimes, and it comes up with just some staggering numbers in terms of these overall estimates. Our own experience in Maine is that we have, in our Maine primary largest medical center, medical system called Maine Health, of the 5 major payers, major insurance companies, there's an ongoing process of negotiation, and there has been, and one and very close to of the companies have accepted the idea of a case rate or bundled funding model. And in one case, there's an agreement on a rate, and now working on all the logistical factors. How do you get these things coded? And I naively would think, well, give us a weekend and we can figure that out. But that's not true at all. This takes a retooling of the whole structure of how things get billed and coded and reimbursed and so on. So we have to pay attention to the details. And I should just say, in terms of an issue about local communication, the initial good news was that all of our 5 payers had agreed in principle to covering coordinated specialty care for first episode psychosis. But when we get into the details, we're down to 1 and probably hopefully 2 of the 5 that are really on board. And the other 3 are in a much more wait and see mode about moving ahead with this. So this takes ongoing work. It means rolling up our sleeves and getting into the details and learning about a lot of things that I sure didn't learn about in medical school. Connecticut has had some success. Dr. Srihari has had some success with getting commercial insurance interested in supporting the model. It's run into some local issues about payment to particular provider organizations and so on that he could say more about, but they may be fairly close. But note also that Illinois, Washington, and possibly other states are including mandating of commercial insurance through legislation. I'm skeptical about that because I think if people are sort of mandated to do something they really don't fundamentally buy into, there may be very, very slow implementation and maybe some serious delays that make it simply not happen. But nevertheless, it's a statement of the will of the people, and maybe over time that can make a difference, and hopefully will. I'm running a little long here. I want to try to wrap this up. So we have to engage our own healthcare provider systems, defining how it's in their interest. And as frustrating and cynical as it may seem, in one's own system, you may encounter the idea that if we're going to reduce psychiatric hospitalization costs, somebody's going to say, or not say, but be thinking, wait a minute, we've worked out the next budget for our next year's budget for our psychiatric hospital, and you're telling me that might be overshooting the occupancy rate. I actually don't think that's a serious problem, but it's maybe an argument for phasing this in and letting systems adapt. The idea at the bottom here of developing coalitions of stakeholders, employers, and benefits managers, I've mentioned before, that's really important. Eligibility criteria, a critical issue is that we're talking about something that's different from the conventional notion of medical necessity, which fundamentally cooks down to the idea that we'll pay for treatment of your illness if you are really, really, really disastrously ill. And this is what we don't want to do. We now have the science and the evidence to say we can identify people who are headed that way before they get there. And so we're wanting to intervene with John Smith at a point when he's still in school, or he's still working, or he's still with his family, probably not functioning as well as he might, for sure, but he's not hitting the level at which we currently would get medical necessity for hospitalization or even assertive community treatment. So this takes some persuading that we really know what we're talking about to identify those who are going to become disabled and high utilizers of services before they get there. Very briefly, Duration of coordinated special care and step down is something that needs to be thought through very carefully. If you just stop at cold turkey, people often go back to the poor trajectory of function. And so a graduated step down with making sure some key elements continue for that individual, but not the whole package may be important. I think using local outcome data, not just the national data, being clear about who we're treating, the credentials and the activities that are involved are really important. So I've gone through a lot here, and I'm going to try to stop so we have some time for discussion. You'll see a bunch of references in the PowerPoint that you can refer to. But there's really been some wonderful work on this over the last couple of decades. So let me stop at that point, and Michelle, let Michelle take over and try to guide us through some discussion. I'm very interested to hear what thoughts people have and what's going on in other parts of the country.
Thank you so much for that really helpful discussion. I'd like to, can you advance the slide one more? One more.
Oh, okay.
There you go. So I want to encourage folks now who are interested in participating in asking questions and discussion to unmute their microphones and turn on their cameras. Also, if you would like to participate by chatting, you can, at the bottom of your screen, there's some place that says chat, and that will open up a screen that allows you to type in questions. Additionally, if you have a list of participants, there's a place to indicate and see all the participants. You can actually raise your hand so that I would be able to call on you if you're interested for that. So want to open up the opportunity for questions. Anybody there?
Hi, Michelle. I think there may be a question also from Tamara in the chat.
Excellent. Okay. Thanks for the interesting presentation. Could you say more about your bullet, payment approaches to step down?
Oh, yeah, that's important, and I kind of went by that pretty quickly. There are a couple of different models that are involved. Overall, I'd say the basic reality clinically with step down is that by the time somebody's been in the program and has really improved substantially, and that varies. You know, some people who really are doing remarkably better in 6 months, other people are really taking that full 2 years to gradually improve and even longer. The team knows a lot about them and is going to know where the points of real leverage might be. And can be actually a remarkably effective consultant to whoever's going to pick up the baton later. So it sometimes takes a little discipline on our part to not hang on to somebody forever, but to pass them over to another clinic that might be geographically closer, or a community mental health clinic, but then to be available in the background for consultation. Or in some cases, for maybe an intermediate level, is that they stay with the team, but they're not using the full services. So now the Meadows model involved what they call an encounter rate, both a block of funding that is there for everybody, and then also an encounter rate. And in the reference, you'll see more about that. So that people, if they're actually now only being seen once a week or every 2 weeks, there's a way to adapt to that. There's an interesting approach that I didn't talk about being done by Dr. Bao at Cornell, Weill Cornell, who's working on a kind of two-component way of funding that also would account for different levels of intensity. So I think this is a work in progress. That the fact is, not everybody is going to need the full blast treatment forever, and that's true of assertive community treatment and lots of other things. Why don't I stop there?
Thank you.
Catherine, hello.
Hi, good to see you again. We were in Washington together not too long ago.
That's right.
I found this slide deck extremely helpful just in kind of how it paints the history and the summary. But one thing that caught my ear was when you talked about kind of the rolling up your sleeves and kind of being in it for the long haul. I mean, in Michigan, I feel like we've taken some stabs at it and we've tried to, we're still at it, but we've tried to learn lessons from Illinois. But when you said on one of your slides, it talked about kind of the challenges involved in kind of influencing legislation, or I wondered if you could speak more about that. Like, how did you guys congregate and organize yourselves to do what you've done, at least with one insurer in Maine? Mm-hmm. And I might have missed what you said about whether you've had an impact on any kind of legislative factors in Maine.
Yeah, the legislation has really been powerful, and I didn't really say enough, and I should say more about the idea of getting family advocates, because they are going to make the case so much more eloquently than we can. We've all got a vested interest in keeping our industry cooking along and so on, unfortunately. But when you've got people who can say, and this happens all the time, my son is showing the same signs that his uncle did when in mid and late adolescence. That uncle is now debilitated, et cetera, et cetera, et cetera. And my son, thinking about a real case here, is graduating from college. He's still ill. He still needs treatment. He still needs careful management. But with that, he's just doing really, really well. So if you get families telling their stories and families who will speak up and say, without this kind of treatment, my son or daughter would not be living. This next suicide attempt might have been, fatal. So at any rate, building that coalition, and that also has included people in major areas of power. People who have no surprise. These illnesses are actually very prevalent in our world, and you'll find legislators and healthcare leaders and insurance leaders who have personal experience with this. So I think that's just an important part. The whole roll up your sleeves part is, I've found, and this sounds, as much as we need to depend on our experts, in the financial and insurance world, we can't just leave it all to them. We've got to stay involved, because questions are going to come up that have clinical implications, or there'll be clinical needs that need to be emphasized, and need attention. Like, for instance, if we're not paying attention to, well, what's it really going to cost the Jones family in terms of deductibles and copays, we're going to lose that family. So we have to be ready to get into the weeds and the details.
Yeah. Yeah. Okay. Thank you.
Doug, I wonder if you can speak to any ideas on how people from different states might be able to work together to learn from each other, benefit from advocacy in order to try to lead to change that might be across states as well.
Well, I think, we're all sort of struggling locally, and it's hard sometimes for us to get the time, attention, bandwidth to connect. But I'm aware of some fledgling attempts elsewhere in New England, and I think something as simple as a monthly phone call, and PEPNet is helpful. We talk with people around the country, but this process, I think this technology transfer center, I think, can evolve into a very good process. So I think some way to have some ongoing work groups that focus on this. There's one sponsor right now with PEPNet and NAMI that can be helpful. I think we have to continue to be letting each other know what's working, what's not, what's easy, what's hard. So I'm just kind of making the plea for this being a community effort, rather than just trying locally and getting frustrated, which can certainly happen.
I would agree. If folks are interested in connecting in other ways following the call today, I'd really encourage you to identify yourself either in the chat or to send an email to me or to the folks that sent you the online discussion forum information in order to and help connect you together for future calls on the subject. We have time for one last question.
Michelle, there was also a question from Angela in chat.
Thank you. You're on top of these better. Will you please share the Cornell resource you mentioned, 2 component strategies of funding that works?
Yeah, I certainly will. I'm sure Dr. Bao will be fine with that. And we have a PowerPoint from her. I'll run that by her. It's evolving as we speak, but I think she's doing some very careful work on this. So I'll get that to Michelle here and figure out how to get it on the list of references that will go out.
Perhaps we could invite her to be a speaker in this series in an upcoming month as well.
Yeah, we can talk more about that. And I suspect she'd be glad to do that because we're all looking for ideas from other people too. It's
Yes.
Nobody's really the expert on this yet. Nobody's got it all figured out. And I think we need to work on this together.
Does anyone else have a last question?
And so now when Bernie's elected, this is all going to happen, right?
I sure hope so.
So we'll see about that.
So to end
Okay,
up,
well, I really appreciate the chance to kind of connect with people, and I hope to be hearing a lot more in the days ahead about all of this.
Thank you so much, and I'm sure that there will be additional questions, discussions. Please feel free to contact me after the webinar, and also want to make a plug for upcoming editions of this series. So our next online discussion series will be on March 11th. That's Wednesday, March 11th at 2. Our guest is Reed Plimpton from the Northeast Telehealth Resource Center, and we'll be talking about the use of telehealth and telemental sessions as a way of expanding access to care for folks who may not easily be able to get to in person a clinic or don't have a clinic that's near them. So we hope that folks will sign up for that session as well. We'll be sending an invitation shortly. Feel free to distribute this to folks that you are in your area that you would really like to learn about these services, folks that make decisions. If anyone knows folks who work in insurance that would want to speak to this and speak with this group as well, we'd be delighted to have as many people who care about this issue of being able to make good quality early intervention services accessible for more of the folks around our region and the country. So thanks again for tuning in, and I wish you all a good day.
Okay, thank you, Michelle.